Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast. Ozcast. Simply head to ozcastnetwork.com for details.
Life is uncertain. It's okay to feel stressed, anxious, worried, or frustrated. It's normal. With CalHope's free and secure mental health resources, it's easy to get the help you and your loved ones need when you need it the most. Call our warm line at 833-317-4673 or live chat at calhope.org today.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, you've brought us together for this episode to discuss hepatitis.
Yeah, that's right. Yep.
But you're steering away from an experiment that is oft talked about. Why is that?
When I started studying hepatitis, I used to always think the viruses were related because I think, they all affect the liver. We'll get to the experiment soon. It's a philosophical, impossible challenge, and we'll see which way you go down. But the viruses, like there's 5 viruses, A, B, C, D, and E, and they are actually all unrelated. There's only one of them that's a DNA virus. All the rest are RNA. And so 2 of them are not encapsulated or non-enveloped, and 3 of them have a lipid envelope. And, 2 of them are sort of fecal oral route of transmission. The other 3 are sort of, have to be IV or, parenteral. And so all these viruses, if you look at it, hepatitis A is a coronavirus, which is a HepaDNA virus. Hepatitis C is a flavivirus. The hepatitis D is actually unclassified, and we'll come to that later. And then hepatitis C is a calicivirus. So they're completely, unrelated viruses, but they affect one organ, which is where they get their name from.
You just read my mind.
Yeah, that's right. And so, when we look at, the liver, and from a current standpoint, we use the liver function test to assess. And so, if you're looking at a liver function test to work out synthetic function, if you're looking at acute liver function, coagulation factors tell you if someone's coagulation factors going off with their liver, that's a really scary sign because it means that the liver is not producing what it needs to produce for you to clot your blood. Chronic disease, we often find we're looking at albumin. So if someone's had long-term liver disease, their albumin starts to drop, and that's because they're unable to synthesize, the big proteins. And then we have hepatocellular function. We're looking at, enzymes like ALT and AST. We look at cholestatic function. We look at ALP and GGT and bilirubin. And, bilirubin is that yellow sort of pigment, and that's where jaundice comes from. So when people sort of talk about jaundice, they're talking about sort of this yellow-orange pigment. And if you see someone who's jaundiced, it's quite a striking appearance. I'm not sure they genuinely look sort of orange all over.
Which is a bit of a trend I see on the music clips, like a very bronze look. But we're not talking bronze.
They even have their eyes sort of go yellow as well. Like they look genuinely, unwell. It is such a striking appearance when you see someone who's, jaundiced. And the history of hepatitis is almost, the history of jaundice, because it's a sign that is everyone sees and it's striking. So it's important, but not everything that causes jaundice is hepatitis.
I was about to say, have we just finally stumbled on the easiest diagnosis?
No, because lots of things can cause jaundice. They either have the problems of obstruction and everything, but jaundice, you can have many causes for jaundice. However, if you have an epidemic of jaundice, well, then that means it's being transmitted. So when you start to look in history, if there's epidemics of jaundice, then that is most likely hepatitis related. And so what we're looking at is when we go back to, all the way to ancient Greece with Hippocrates, he wrote in De Morbis Internis, he described a benign epidemic of jaundice. And you can actually find them scattered through history. There's the 5th century Babylonian Talmud, which had ancient Chinese literature in 200 CE. They mention these epidemics.
You say benign.
Well, benign because people don't die from it.
Right.
And so they would be unwell, but it wasn't people dying left, right, and centre. So it seemed they were unwell, but they weren't really unwell. And so jaundice is an old French word, which means yellow. And there's also another term we call icterus, and that's a Greek word. Now, that's actually derived from a yellow bird called the golden thrush.
Yes, I know. We haven't done an episode on thrush yet, have we?
No, we haven't. But what I saw was, through the reading, the ancient and Jewish and Greek cultures, that the bird, the golden thrush, they thought that if they got that bird next to a person's umbilicus who was suffering from jaundice, it would help to cure them, to get them better.
Did it?
No. But the thing is, the theory was if they improved, then the bird would die. So it was sort of this unusual, it would cure you, kill the bird, so you would almost transfer it to the bird. And so, again, as we get later on in the centuries, we're looking at, this is reported by things such as people such as Virchow, Bamberger, cocaine in the 20th centuries. And we got countries who just have it in their history, 17th century, such as Germany and, Flanders. What they called it was catarrhal jaundice. So they referred to this as a catarrhal experience of becoming yellow. And so probably the most interesting and the most influential for us this day is what the military called campaign jaundice. And Napoleon's troops had experiences of campaign jaundice in Russia and Egyptian campaigns. The American Civil War had 70,000 people who became ill, and also in the First and Second World War. And in fact, the greatest advances was because of this. Now, if we go back a little bit before the Second World War, in 1931, there was some doctors and scientists who did some research on this. His name was Findlay, Dunlop, and H.C. Brown, and they presented a paper called Observations on Epidemic Catarrhal Jaundice. And they concluded that it was caused by an ultramicroscopic virus, and it was only pathogenic to man. Now, the challenge with this was that H.C. Brown, while he was handling some of the serum, became sick himself 5 weeks later. And so he was handling it from the outbreak, and he got sick himself. And so that takes us to the Second World War. And this matter was treated really seriously because what ended up happening is they had epidemics of jaundice from the troops. There was an experience in North Africa when both Allied and German troops became ill with jaundice.
Hang on, how does that happen? They wouldn't be necessarily mixing in the same circle.
Well, I'm not quite sure how it happened, but I'm guessing if someone was, you're fighting and then some people jump into the troops, And
could it be environmentally born as well?
Well, this one, not likely, one, but this would be person-to-person transmission or something contaminated was transmitted. So even water supply could have actually caused this epidemic.
Right.
And so then in summer of 1942, US have 50,000 men that ended up being seen, estimated 300,000 infected, and 62 people die. So the amount of people dying from it isn't significant, but that's a lot of people who are unwell with it. And we'll come back to the reason why this happened. In 1943, the US invasion of Sicily, they had experienced jaundice, the troops. And then in 1945, the US invasion of Germany had 200,000 cases of this jaundice. And so they're trying to work out what this is, what's going on with it.
I'd be checking the caterers at this point.
Well, they did. There was people who were doing research, a person by the name of Cameron, who was with the British troops in Palestine from 1941 to 1942. And what he got was 7 volunteers, and he used either whole serum or blood from jaundice patients. And then what he did was he ended up injecting those volunteers. Now, one of them developed jaundice after a month. And then he collected serum from that patient and put it into 5 more people and, well, volunteers. And then all of them became jaundice. Now, he ended up, the experiment, he ended up abandoning the experiment because they eventually found out from other people doing experiments that people could die. So he did stop that. But there was also a Yale experiment that got volunteers and injected them with serum. And they started injecting it at different times, meaning that one time they did it at 11 days before the onset of symptoms and then 31 days after the onset of symptoms. So you can see they're trying to work out how infective and when it is infective.
Where do I sign up?
And so there's lots of human experiments going on. So this problem eventually ended for the US because the war ceased. But the US military were very concerned because this interrupted the war effort. And
also they have care for their soldiers too.
Well, there was a campaign to be completed, and if your troops are ill, then they can't go and kill other people, which would probably be, I guess, a big problem in the army. But looking at it, what they ended up doing was they created or established the Armed Forces Epidemiological Board to look into this further. And this was what they were able to find out before this was, well, they knew that there was a transmission. So some was fecal contamination from going from one person to the next, and some were involved in the serum. And one had an incubation time which was short, which was about 20 days or so, and one was long, about 90 days. And so what they found during the war, now the 1942, it seems to be a significant date, was that this had a 90-day incubation time. And there was people, the 50,000 troops that are mentioned, all of them had received a yellow fever vaccine. And so it turned out that it had been contaminated. They had used human serum at that point in time to stabilize it.
Yeah.
And then injecting it to try and prevent them getting yellow fever, it had accidentally given them hepatitis. And so they ended up at that time destroying the rest of the vaccine and not giving that particular one to any further troops. And the epidemic in that area stopped. And then they used the yellow fever vaccine that didn't use human serum in it. And so they were able to find, well, that was the cause for it. But they still didn't know what actually caused it.
And on the fecal transmission, is that not washing your hands?
Yeah, so it's poor hygiene, and it's transmission, just like gastroenteritis.
Yeah.
And the problem is, normally you might not have the best hygiene in the trenches or, in wartime, and so it would spread really easily. And not only that, because of all of this going in, what they found was that people who got the jaundice, through the serum or the yellow fever vaccine could actually become jaundice again, and with the other one, meaning that they could get sick again, but it must have been different.
Yes,
because normally you'll be immune to something you've just hadn't gotten over.
Well, at the time of recording this, there is a new variant of COVID, and there is some talk in some circles that our current vaccines, will they or won't they give us any protection on this? And
so what they're looking at it going, well, these must be two different diseases, because someone who's had jaundice before with this version can still get jaundice with the other version, but those who had the other version wouldn't get sick again. So it was putting the pieces together for the puzzle. And this was pretty unusual. And this takes us to an interesting time, the 1950s. Dr. Saul Krugman, who was a former flight surgeon in the US, the Air Army Corps. Now, he was a pediatrician in New York.
Dear listener, be nervous because there's some really interesting facial expressions.
Yeah, he wanted to create a vaccine for hepatitis.
Right.
And so he proposed a study to research this with the armed forces, the Epidemiological Board. And this was to be done at Willowbrook State School, which was a school for the severely developmentally challenged children. This was a school who, it was overcrowded, inadequately staffed, and they had a hepatitis problem among children and the staff there.
Okay.
And so, just as an example, Willowbrook was having trouble with overstaffing. They ended up sending like 5,000 letters to parents pleading for them to take the children because of the poor conditions. Only 24 parents responded, and only 2 children were taken away. So this is a really big challenge for that school. So only 24 parents responded, and only 2 children were taken home. And so what they wanted to do effectively was study the natural history of the disease. And it was, if you knew the natural history, you would know how to prevent it, just like we mentioned before. Washing your hands, could that do it? Mm-hmm. And then eventually they wanted to create a potential vaccine. And so this is almost one of those philosophical impossible problems. Would you experiment on children of a disease that they're probably going to get anyway to prevent future children getting that disease? It's just, now, they went down this line. This study went from 1955 to 1970s. And the official documentation says it was to, parents were given informed consent, and they were shown the experiments that they were going to do, and parents went ahead with it. The other side of that is parents almost felt that there was no other option for them with these severely disabled children, that then eventually, in an overcrowded institution, they either had to sign on to the experiment or not. And so these children were either injected with the hepatitis virus or given contaminated drink to have for the experimentation.
Of course, that wouldn't get past an ethics board today, would it?
Exactly. And the whole impetus behind this is this experiment then led to the development of the National Research Act in 1974. So it revolutionized everything about how you use subjects in a human experiment. But it still happened. These children were still experimented on. And it was just an unusual time.
Well, it is. And also, it's hard to, you said about this being a psychological exercise or a philosophical exercise, without being in their shoes, because I know some people from the MS end of the spectrum who are desperate to be used in any experimentation for any new advances whatsoever.
Yeah.
Come hell or high water, they were happy to do it because they want to contribute. So unless you've been in that situation, it's tough.
Yeah. Look, and that aside, we were, with all of that experimentation then changing, then in the late 1960s, we get Dr. Barak Blumberg, and what he was studying, so completely separate to all of this,
right?
He was interested in genes and disease susceptibility. And so he studied patient serum from around the world. And then what happened was, in one experiment, he mixed Indigenous Australians' serum with that of a patient who had haemophilia and had multiple blood transfusions over time.
Okay.
And this has had a reaction. And this reaction he called the Australia antigen. And so this ended up getting the Nobel Prize in 1976. What he had found, this Australia antigen, was the hepatitis B surface antigen. And so this is what we use for vaccination. Oh. And so all of this experimentation, you've got everything going on, all of this, the war effort, these epidemics of jaundice, the experimentation, the self-experimentation, the troop experimentation, children experimentation, serum that's then mixed with other serum and finding a reaction, you have what we have, catarrhal and campaign jaundice. And effectively what they said was the serum hepatitis, they called MS2, and the other hepatitis, so the one that is benign most of the time and you would get through food, fecally contaminated food, was MS1, which was hepatitis A. So we have hepatitis A and hepatitis B. But as you know, we've got a whole...
Yes, an alphabet worth.
That's right, to come back to.
Just on that, before we finish and get ready for the next part of this, Dr. Travis Brown, when you were growing up, or had your children growing up, did you feed them alphabet soup and just hepatitis A, hepatitis B, hepatitis? No?
So we've got A and B, but as you can see from the title, there's C, D, and E.
Yes.
And as soon as you classify one disease in a group, you suddenly realize that there's a bunch of other ones that don't quite fit. And this is clearly around that time, 1970s, 1980s, you've classified A and B effectively. Mm-hmm. But then you'll find out that there's ones that don't fit, and they become non-A, non-B hepatitis. And so it goes into a catch-all. So knowing that it's in that category is probably straightforward. Knowing what it is takes a bit of a challenge. And so that's where the science and the brilliance comes in. So then we get a number of, studies, really. And so the first one comes up, hepatitis D virus. And that was discovered in 1977 by the name of Mario Rossetto. And he was studying hepatitis B. He was studying it in serum as well as liver tissue of carriers. Now, the interesting thing about hepatitis D is it's a defective virus, which is why it's unclassified. It has to exist or coexist with hepatitis B to be infective. Oh. And so it can't. You can't have hepatitis D without hepatitis B. And so he discovered what we call the delta antigen and delta antibodies. And so the important implications from this is it tends to have a bit more of a worse progression because you have hepatitis B and hepatitis D, and it can accelerate the course of hepatitis B. And we'll discuss that a little bit further later.
Just before we go further, question without notice, why was it not just called hepatitis B something given that you can't have D without B?
I'm not sure. You can have B without D, but you can't have D without. Look, I don't know. I guess it's just one of those classification things. It's a separate virus because it's actually, remember, hepatitis B is a DNA virus. Hepatitis D is an RNA virus.
Right.
So they're two distinct entities, but effectively the D has to have B to exist.
Gee. So this must make it hard for the armchair epidemiologists at home on Facebook. All this variation.
Look, it's a challenge in itself, and it's hard for doctors to know when it's relevant to test, and that's that's what we'll delve into in a little bit. And then you have the hepatitis E virus, and this was discovered or started to be studied in 1978 by Dr. Muhammad Karu. Because there was an outbreak in Kashmir in India. And this happened over the space of, the study was 14 years. Mm. And it was over 200 villages were affected, had a population of over 600,000. There was about 52,000 cases of jaundice and 1,700 fatalities. But the interesting thing about this is pregnant women were overrepresented, meaning that seemed to be that women who are pregnant with hepatitis, with this, what would become hepatitis E virus, were more likely to die from it. And so the problem that this study has was there was hard weather conditions over the time. There was lack of basic health care in these areas. And, there was no, investigative facilities at the time. But what he found was, a lot of the patients were the age between 15 and 45. It was self-limiting disease, and there was no chronic state. So people didn't just continually have episodes. It didn't cause cirrhosis. But again, he confirmed that, yes, pregnant women and fetal death was increased, overrepresented in the fatality cases of hepatitis E. And not only that, there was an outbreak in the Russian military personnel in Afghanistan. There was a Dr. Mikhail Balanian, and he did self-experimentation, which seems to be the...
It's a theme of this podcast.
Well, yeah, and look, he ingested pooled specimens from, 9 different patients on himself, and he developed severe acute jaundice, he had hepatitis.
Is he still eligible for sick leave in those situations?
I don't know, but it's just, he was able to visualize under electron microscopy what he called virus-like particles, VLP. So he confirmed that was there.
Excellent.
And that brings us to, hepatitis C. And so this is a combination of people for, finding it out. So there was a study conducted in 1978. So again, this is a significant time because, again, you classified A and B, and then there's a whole bunch of classifications that don't fit, which is why it's happening around this time. And so there was a study conducted by Harvey Alter, and he had a patient, there was a blood donor with chronic hepatitis and 4 other people who had this chronic non-A, non-AB hepatitis. And from the blood transfusions that they had received. And so using their serum, they injected it into 5 chimpanzees. And the chimpanzees all developed hepatitis. Mm-hmm. So they knew that there was a hepatitis in that serum, but they didn't know what it was. It wasn't until 1989 that Dr. Michael Horton, who was a virologist, using the blood plasma of non-A, non-B serum, constructed a complementary DNA library and found in the serum that there was a flavivirus, an RNA virus in there. And what we was able to do with that was he was able to develop a test to identify antibodies to that virus. And that was in 1992, which means he was able to find a response to that virus. This response was to hepatitis C.
Yeah.
And so we then have, people who were giving blood donations able to identify hepatitis C. And that's the problem. Anyone receiving blood products before 1992, we weren't able to screen for people who had hepatitis C. And so people who were receiving regular blood transfusions or just blood transfusions for whatever reason had a risk of getting hepatitis C. And that brings us to Dr. Charles Rice, who was an American virologist, and he constructed a full-length clone of hepatitis C. And he injected this into chimpanzees who developed hepatitis and the hepatitis C antibodies. And so that combination, so Harvey Alter, Michael Horton, and Charles Rice together received the Nobel Prize in 2020 for the discovery of the hepatitis C virus. And we now get to a point where people like Dr. Ralph Bartenschlager developed an in vitro cell culture from a human hepatoma cell line, and they're able to replicate hepatitis C. And so this revealed the biological features of hepatitis C and helped to produce anti-hepatitis C agents we now call direct-acting antiviral drugs. We can cure people who have hepatitis C. And so this is the remarkable progression of where we find ourselves that, yes, there are 5 viruses. We can prevent a lot of them through vaccines, and we can even cure one, which can affect millions of people's lives and prevent them from getting some of the complications that we'll discuss in soon.
Did any of the chimpanzees share the Nobel Prize?
I don't think so.
Just before we get to the last part of this exploration of hepatitis, the anal retentive aspect of me, Travis, is wondering why hepatitis C wasn't identified or named until after D and E, or is that just how you have progressed the reporting so far?
Well, remember that the hepatitis E was one that took 14 years to identify, which still would have been, It would have been 1978 that it started, 14 years, so around 1992. I think it would have probably been labelled at some point in time. Hepatitis D, was called a delta antigen, delta antibody. And so it would have taken a while for it. So I'm not quite sure if it's the sequential nature of it. Again, I'm not sure.
That's okay. I just like throwing questions without notice. That's all.
That's fine. But look, if looking at it from a perspective, from a testing perspective, or even just a disease perspective, the easiest way I can put this together is almost in groups. And I sort of group A and E together, hepatitis A and E. And the reason is because they're both non-enveloped viruses. They're both a fecal oral route of contamination, that contaminated water, that's how they're transmitted. They can cause an acute illness, cause jaundice. They're both self-limiting, and they don't have a chronic version of their disease. You'll have the episode, you'll pretty much recover from it, mostly. There is a transmission difference. So hepatitis A can be more person to person, whereas hepatitis E seems to be, it's not common for it to be from person to person. So, which seems odd, but that seems to be the information that we have. The other thing about hepatitis A is sexual transmission is important, particularly men who have sex with men, because of the route that it goes through.
Oh, yes, so, the fecal. Yep, right,
yeah,
sure.
And so that's important to keep in mind for patients who are sexually active, men who have sex with men. So it would be recommended for those people to be vaccinated against hepatitis A. But I mean, the other thing is, looking at epidemics, hepatitis A can survive long times in seawater, and you can get outbreaks through contamination of oysters and cockles. Oh. And so one of the biggest outbreaks happened in Shanghai with, over 300 cases of hepatitis A, where they sort of draw it back to, contaminated oysters, and it can last in, weeks in, contaminated sea water, it seems. So
I knew there was a reason I don't eat oysters. I've got the evolutionary strain that protects me.
Well, the other problem is there's been cases where contaminated lettuce and ice slushies, frozen strawberries and salads type things. So maybe you should strict them from the
it is the
diet as well.
The breakfast of king, a strawberry ice slushie with an oyster.
Yeah. So look, and if we look at the incubation time, the average is about 30 days. So when someone gets exposed, about a month later they'll have it. That ranges between 5 to 50 days. And a lot of people will have a prodromal sickness. Before they get jaundice, they'll feel unwell and feel malaise. But the problem with hepatitis A is its infectivity period is so long. So you can be 2 to 3 weeks before you have jaundice and 1 week after the onset of jaundice. So that's a pretty big time where you are infective. And that's why it's a public health problem, is because you can infect a lot of people during that time. But the amazing thing about this virus is that 90% of children under the age of 5 are asymptomatic. And so for whatever reason, they get the virus, but they don't show any signs of being unwell or being jaundice. And 70% of adults will show jaundice. And so when we talk about a prodromal illness, what these people will get is bilirubin in their urine. So they get a really dark urine. They will tend to get pale feces, and they'll become jaundice. And so the liver enzymes, when we talk about acute hepatitis, we need things like ALT and AST, so what we test in the liver function, to be in their thousands. So if they're not in their thousands, we tend to say, look, it's not acute viral hepatitis. If it's in their thousands, yeah, it really could be. And what ends up happening is these people are unwell for about 3 or 4 weeks. Eventually, their liver enzymes begin to normalize. And when I said, what we talk about fulminant hepatitis, so when you go from fulminant hepatitis, we're talking about acute hepatic failure. You're going to go into liver failure. It's really rare with hepatitis A. It's, there are a few risk factors for people if you tend to be in an older age group, or if you already have a history of chronic liver disease, such as, especially hepatitis B or hepatitis C, then your risk factors for developing fulminant, hepatitis increases. Now, hepatitis A, it's not more severe in pregnant women, and the fetus is not, health or survival is not affected. And so, very different to hepatitis E. So, whilst they're similar, there are some features that are very different.
Right.
And so, by the time someone presents with, a really good jaundice with hepatitis A, 95% of the time they will have what we call an IgM, positive hepatitis A. So serology is really good for people with hepatitis A, and IgG persists for life. So once you've had, hepatitis A or you've had the vaccine for it, pretty much it's lifelong immunity.
Well, there's a silver lining in everything, isn't there?
So that takes us to hepatitis E. And look, this is... there are countries where it's more common. We don't have it, sort of developed countries. Australia doesn't have it so much. There are places in India, Egypt, and some parts of China where it's endemic. And in the endemic regions, people who get hepatitis E can be subclinical, so they not show any signs. But severity does increase with age.
Should a GP also be a little bit more alert when someone from those cultural backgrounds is attending?
It will be more travellers. You'll be more worried about it. So people who've come from that area probably will have had it, but unless they're just recently coming across, then, because again, there's not a chronic state.
Right.
And so it'll be more people who go into that area. They actually have to be careful with what they eat and drink, because you can get contaminated water, and then they can get hepatitis and be unwell coming back. So again, with hepatitis E, there's no chronic phase of this disease, and less than 1% develop fulminant hepatitis. So it generally takes about 4 to 6 weeks to recover, and the antibodies for hepatitis E will develop after about 2 to 6 weeks. But we do know for hepatitis E that the people who are the highest risk are pregnant.
Right.
And so if there is a 15 to 25% mortality rate of pregnant women with hepatitis E. It's unclear why. We don't know why. And particularly seems to be bad in the 3rd trimester. So people who are far along in their pregnancy. And so that's why we sort of group hepatitis A and E together. They're very similar type of presentations. There's a few differences, but those subtle differences are actually quite easy to remember. Yeah. But that takes us to the body fluids hepatitis, so B, C, and D. And look, I inherently link B and D because
they are linked.
Exactly. And so when we look at B, it can get a bit confusing from a testing point of view, because there's a few antibodies we test in this area. There's hepatitis B surface antigen. There's hepatitis E antigen, which E means early, and we use that as a marker of infectivity and replication. So if there's an active infection going on, you'll have hepatitis E antigen. If there's been recent infectivity and reactivity, you will have hepatitis E antibodies. And so we can sort of see, yes, you have been, recently infected, or you are being infective with hepatitis E. And then we have the core antigen, so hepatitis B, C antigen. Now, what we use that for is we know when we give you a vaccine, we only introduce the surface antigen to your body. If you have core antigen, it means that you have actually got it through natural infection. So because we don't give core in the vaccine. So if someone's got core antibodies, at some point in time, they've had a natural infection of hepatitis B. And so who is at risk of hepatitis B transmission? Well, it's people who have blood products. You can get it through, also the other way, you can get it through IV drug use. You can get it if needles aren't clean in things like acupuncture, tattooing, body piercing. You can get it through household contact. So if someone has hepatitis B in your household, they can get contaminated surface, and you can actually get hepatitis B in that instance.
So if you're I'm just thinking of my youth in a share house,
Yep.
and someone is an intravenous drug user or getting tattooed by someone who without high hygiene, you're susceptible.
Yes, and so that's why household contacts are recommended for people who have hepatitis B. If they're a chronic carrier, yes, you would recommend household contacts to be vaccinated against it to stop them getting it. Right. There is also risk of sexual contact, as well as prenatal exposure, which we'll come to in a little bit. But what clinically the patient, a lot of patients are subclinical. So people who get hepatitis B may not have many signs at all. 40% will develop jaundice, and fortunately, again, less than 1% develop fulminant hepatitis, so, hepatic failure. But the interesting part about all this is the highest risk is perinatal transmission. So a mother who has the infection, if they pass it on to their child through childbirth and everything, then there's a 90% chance of the child becoming a chronic carrier. So it's very interesting. We'll come back to that point. But the acute hepatitis in hepatitis B, infants, it's very rare to have any symptoms. Only 6% of children who are infected show any signs, but about 1/3 of infected adults do. And so the important part, which we'll come back to again, is hepatitis D, if they do have it, tends to have a more severe course. And that's just, you've pretty much got two infections going on. So again, with the chronic, so hepatitis B does have a chronic phase.
Right.
And again, so 90% of perinatal infections will become chronic carriers. Children of the age of 1 to 5 years, about 20 to 50% of them will become chronic carriers. And interestingly, less than 5% of adults who get a hepatitis B infection in adulthood become chronic carriers. So if you get it as a newborn, you're most likely to become a chronic carrier. If you get it as an adult, you're most likely to clear the infection. And so what do we call a chronic carrier? It's someone who has a surface antigen detectable for longer than 6 months.
Right.
And so that puts us into, you most likely have a chronic infection. But the interesting part, and we're coming back to the perinatal, a mother who has, if she has an active infection, so when we talk about surface B E antigen, if she's positive for that, the child has a 70 to 90% risk of infection. If she is negative in the surface B E antigen, she only has a 5 to 20% risk of the child becoming infected.
What if her status changes?
Well, you have to manage the hepatitis B during their pregnancy.
Right.
And so you'll want to make sure that they don't have, as best they can, an active infection during birth or during pregnancy. Yep. And so that's the interesting part is that most chronic carriers are asymptomatic. And so the problem with hepatitis B is about 15 to 20% of chronic carriers will develop or can develop cirrhosis, so fibrosis of the liver. And they also have an increased risk of hepatocellular carcinoma. So again, this will just be monitoring the patient. And look, serology is really effective in hepatitis B diagnosis. Often you monitor the hepatitis B surface antigen if they've had an infection to see that 6-month marker. and identify patients who become chronic and need regular monitoring and those who resolve the infection. There is PCR, but you can actually identify the virus. But again, serology is, excellent at identifying with the surface antigen for usage. The important part for healthcare professionals to remember is you can vaccinate. And so people who are at risk, particularly healthcare professionals, household contacts, all can be vaccinated and protected against this. The magic number we keep is we want your surface antibodies, so against over 10. And if you're over 10, then chances are you get exposed to hepatitis B, you will be protected and won't get infected. And so that's why people talk about, if you've got less than 10, if you're a healthcare worker or even a high risk exposure, we want to give you a booster to get that level up. And so if in the unfortunate instance where someone is exposed to it, we do have hepatitis B immunoglobulin, HB, IG. And so these are people that we give you the antibodies if you're exposed. The only problem with that is it needs to be as quickly as possible. And if it's greater than 24 hours, the effectiveness
goes through the floor.
That's right. So you want it within the first 24 hours of your exposure. So if someone happens to be a healthcare worker, unfortunately it does happen every once in a while, that isn't vaccinated and then is exposed, get them immunoglobulin as quickly as possible to try and prevent an onset of an infection.
I'll just add it to my shopping list.
And then that brings us to the hepatitis D virus. So again, it's defective. It accelerates the hepatitis B infection, and it requires the hepatitis B virion assembly and secretion. So that's what it pretty much piggybacks on hepatitis B to infect. And again, you think about it in the same way as hepatitis B, it's pretty much transmitted the same way. So the people who are at risk of IV drug users, highest rates tend to be in IV drug users and patients who have hemophilia. But it can also occur in body piercing, tattoo, and sexual contact. So what we often classify this in is co-infection. So if someone has been infected both with hepatitis B and hepatitis D together, it's sort of called a co-infection. Now this is usually transient. It's usually self-limiting, but it tends to have a bit more of a severe presentation because, again, you've got two viruses. And if it does end up taking hold and becoming chronic, you have a more rapid course of cirrhosis and liver failure. So that's the problem with hepatitis B. It just makes things worse. And so the chronic infection question is you actually can't have chronic hepatitis D infection without hepatitis B. So that effectively, can it be chronic? Yes, but it has to be with B, and you have to be effectively a chronic carrier with B. The next level we have is if you have hepatitis B, you have and get D. We call that a super infection. It means that somehow you've acquired D while you already had B, and the chances are you're already a chronic carrier with hepatitis B. And what we know about that is it tends to be a worse course. And so if you get them together, you'll probably clear it. If you get one on top of the other, you're probably already a chronic carrier for hepatitis B, and then you get D, and it will make things worse. And so we also tend to be very wary of patients who are co-infected with hepatitis C as well, and HIV. So any of these patients who have hepatitis B and D, it's recommended to do HIV and hepatitis C screening because they are at risk of those diseases as well.
Do you have any idea of the mix of those who get B and D together and those who have the super infection?
No, I don't. It goes into the area, the people who look for D the most are actually tend to be in the clinics of hepatitis clinics. And because the people who have hepatitis B, chronic carriers, will tend to be, seen by a gastroenterologist or reviewed by people knowledgeable in the area. And so if you don't have hepatitis B, you won't have hepatitis D, but hepatitis B, D are at risk of D. So it sort of tends to be a very segmented population who look after these. And so that takes us to hepatitis C. Now, hepatitis C, it has an incubation time of about 6 to 8 weeks. And serology is about the same time, so 8 to 9 weeks before you become positive. And so that's the challenge of it is, if someone's been exposed, it's actually a few months before they get a negative serology test before you can actually say, no, you haven't been exposed. The other thing is you can do hepatitis C RNA PCR. So that is actually looking for the virus itself. And in certain instances, that can be positive into 1 to 2 weeks of exposure. So that means the virus is in your blood. So that is an alternative. But the people who are at risk, again, people who have had blood products before 1992, the magic number before we could test for it, people who have intravenous drug using, needle sharing, patients on hemodialysis, patients who have organ transplant recipients, tattooing, particularly with needle sharing. There are things, people get tattoos like in prison, so amateurs using needles to tattoo. And there's also perinatal transmissions. And the role of sexual transmission is controversial. And the risk of a long-term monogamous couple passing hepatitis C on to their partner is actually really, really low. And so it's said that it's not much, but it's always said to be low. The problem is if someone's co-infected with HIV or has very high hepatitis C viral loads, then the risk appears to increase. And if you have multiple partners, again, appears to increase. So there is some risk of perinatal transmission, so mother to child, but the risk seems low without HIV. So there is an association between passing on hepatitis C with HIV. And so if someone doesn't have HIV, their risk of passing it on to their child in perinatal period is about 5%. If they have HIV, it goes up to about almost 20%. And so the role, unclear. Is it because they're immunosuppressed? We're not sure again. And so the risk that it's passed in breast milk, it's not passed in breast milk. But if the mother gets cracked nipples while they're breastfeeding, or if there are lesions around or in the mouth of the child, then the risk is
increased.
That's right, and it's recommended not to breastfeed at that time. So the amazing thing about all of this is that acute infection, majority of people are asymptomatic. About 10 to 20% get, non-specific symptoms like, anorexia, malaise, and abdominal pain. Less than 25% get jaundice. And so this is, for the vast majority of people, if it is an acute, if they get acute symptoms, it only lasts about 2 to 12 weeks. And severe infection is rare. So someone might just feel unwell for a while, but they've actually acquired a hepatitis C infection. And so that can be problematic because 75 to 85% of these people become chronic carriers.
So someone could have this, not see a doctor, and it sort of pass after 12 weeks, but they might have transmitted it to others in that time.
Well, and again, yes, it's one of those ones where they can, they won't be positive. So even if you were to test them in the first month, they might test negative and just think, I've been unwell for a little while. And so that's the challenge of this is knowing sort of the disease process, knowing that it takes a few months for antibodies to develop, and knowing the risk profile of the patient. And not a lot of people, it will sound weird, not a lot of people come out and say, yes, I've used IV drug use just off the bat.
No.
And sometimes even when you ask them directly, they might be, coy about it. But, this is why it's really important. Anyone who has ever had, a history of IV drug use deserves to get a hepatitis C test because they could be a carrier and not know it. Yep. And so that's why, again, the majority of hepatitis C patients who are exposed to hepatitis C become chronic carriers, about 80, 85%. And so they can then go on and infect other people, particularly if they're using, sharing needles or anything like that. And so the most common symptom that most people get is fatigue, though. They will get maybe some abdominal discomfort. There's this interesting symptom where they talk about intolerance to alcohol and fatty foods. And so that being said, making it even harder, about a third of patients have normal ALT, enzymes from the liver. So it looks like their liver's probably fine, right, but they could even have a hepatitis C, and we don't have any signs on the testing. And so the problem with that is if 80% of people get, become chronic carriers, about 15 to 20% of these patients progress to cirrhosis and complications. Now that happens over 15 to 40 years. And it's accelerated if the patient, has, alcohol consumption, if they have HIV as well, or even if they have a chronic hepatitis B infection. And so, again, who should we test? If anyone's ever had IV drug use, if they've had blood products before 1992, if they've had, extensive hemodialysis, or if they've ever had liver disease and we didn't know why they've had liver disease. Other patients to consider, certainly HIV, anyone would be recommended to have HIV and hepatitis C testing, and then sexual partners, multiple sexual partners or anything like that, consider hepatitis C. It's not if they're in a long-term monogamous relationship, again, the risk is really low, but regular sexual partners, it should be considered. And here's the thing, the testing, again, be wary of the acute testing. So if someone's presenting feeling unwell, only about 50 or 70% will have positive serology. If they test it again in another 3 to 6 weeks, well, that percentage increases, but that's because, again, the natural history of our antibodies. But if someone's immunosuppressed, they may not develop antibodies at all. And so the question I get a lot from clinicians is, I've got an equivocal result of hepatitis C. Now, what does that mean? It means that when we test it on serology, on an assay, we often get a low positive result. We don't take that on face value. We confirm that with a second test because, again, you can be somewhere in the process of developing antibodies. And what often happens is on the second assay, we get negative. And so you've got a low positive and a negative. You result that as an equivocal result. What does that mean? Well, it means once you get that result, you're permitted by Medicare in Australia to get a hepatitis RNA PCR, and that will determine if the virus is there. And more often than not, it's actually negative. And what happens is that low positive often always stays low positive on that assay, but you've just got some non-specific reactivity. Right. And so the whole point behind that is PCR is useful for confirming in hepatitis C positive cases. It's also useful in unexplained liver disease, and we also consider it in children who have affected mothers, and because you can test them between the age of 2 to 6 months of age, whereas serology you have to wait till 15 months before that becomes positive. In patients with hepatitis C, it's recommended you get hepatitis A and B vaccinated. And the amazing thing, as we alluded to before, is that hepatitis C can be treated and it can be cured. Now, the World Health Organization estimates that there's about, in 2019, 58 million cases globally of hepatitis C. Interesting, only about 20% of people know their diagnosis of hepatitis C. And what they estimated, again, is that only about 62% of the 21%, so about 9 million people, were treated in 2019.
That's a lot of people out there.
So there's a lot of people that...
undiagnosed.
Exactly. Yeah. And the whole thing behind that is the World Health Organization recommends people in, pretty much developing countries to get the DAA treatment, the direct treatment for cure. And that's recommended for people over the age of 12. And this is a course of about 12 to 24 weeks, regardless of the genotype. And I haven't touched on the genotype, but we do have different types of genotypes in hepatitis C, the 1, 2, 3, 4. And the reason that's important, particularly in places like Australia where we do genotype testing, is that tells us the likelihood that you're going to respond to the treatment. So if you've got genotype 2 and 3, there's an 80% chance that you're going to respond to the treatment for a likely cure. The problem is for genotype 1 and 4, it's only about 50% chance, but that's still worthwhile knowing if you have the facilities to be able to do it. but we can cure hepatitis C now.
Dr. Travis Brown, thank you again. And yet another episode impacting my life. During the school holidays coming up at the time of recording, I'm going to remove a few activities for my daughters. One is the do-it-yourself tattooing. We won't do that. And also the oyster appreciation menu. I think we'll just give that a rest for a year. This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjud. This has been a Pathnotes Proprietary Limited production.
Life is uncertain. It's okay to feel stressed, anxious, worried, or frustrated. CalHope can help. Access CalHope's free and secure mental health resources. Call 833-317-4673 or live chat at calhope.org.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.